Extending treatment criteria for Barrett's neoplasia, results of a nationwide cohort of 138 endoscopic submucosal dissection procedures. Introduction. Endoscopic resection of early neoplasia in Barrett's esophagus, BE, is mostly performed using the multiband mucosectomy technique. Multiple large studies have shown that this technique is a safe and effective treatment for early BE neoplasia, i.e. less than or equal to SM1. A technical limitation of using this approach is that lesions larger than 20 millimeters must be removed using multiple adjacent resections in a so-called piecemeal fashion. For early BE neoplasia, i.e. low-grade dysplasia, LGD, high-grade dysplasia, HGD, or esophageal adenocarcinoma, EAC, limited to the superficial submucosa, M1 to SM1, piecemeal resection is an adequate approach. While the risk of lymph node metastasis in mucosal EAC is minimal, this risk increases for cancer invading the submucosa. The risk also depends on other histological factors such as grade of differentiation and presence of lymphovascular invasion, LVI. In addition, adequate histological assessment of the deep resection margin is important to determine the optimal treatment strategy, which may range from endoscopic management to surgery. In the case of submucosal invasion, accurate histologic assessment is thus of the utmost importance, and piecemeal endoscopic resection may compromise this. Furthermore, in the case of bulky polypoid lesions, the intraluminal part of the lesion may fill up the multiband mucosectomy cap, preventing complete removal of the lesion at its base. Endoscopic submucosal dissection, ESD, might offer a solution in these cases. ESD was pioneered in the early 2000s in Japan to facilitate en-bloc resection and controlled complete excision of a tumor. ESD entails meticulous tissue dissection in a fluid-expanded submucosal space, offering precise control over resection depth and lateral extent. ESD enables en-bloc resection independently of the size of the lesion and its intraluminal extent. Nevertheless, ESD has inherent disadvantages compared to multiband mucosectomy, most importantly greater technical difficulty, a longer learning curve, and longer procedure times. Multiband mucosectomy is therefore still the preferred approach for most early BE neoplasia, whereas ESD will be preferred in lesions with suspected deep submucosal invasion and in lesions where a cap-based approach is technically not feasible. An important driver for the use of ESD for early BE neoplasia is the expanding indication of endoscopic treatment for submucosal cancers. Current guidelines advise esophagectomy for lesions with deep submucosal, SM2 to SM3, invasion given the risk of local lymph node metastasis, but this is based on surgical studies that are limited in quality and quantity. Recent series of endoscopic treatment of submucosal cancers indicate that this risk may be much lower than generally assumed. In the Netherlands, BE care is centralized in 9 Barrett Expert Centers, BECs, with a common treatment protocol, a joint training program, and regular meetings with case discussions. Performance of ESD is super-centralized to 6 high-volume centers, all of which have participated in a specific ESD training program and have adhered to strict indications for ESD as an alternative to EMR. In the current study, we report on a nationwide cohort including all ESDs for BE neoplasia performed in expert centers in the Netherlands between 2008 and 2019 in order to evaluate clinical outcomes. Methods: retrospective assessment of outcomes using treatment and follow-up data from a joint database. Results: 130 of 138 patients had complete ESDs, with 126 of 130, 97% en-bloc resections. Median interquartile range, IQR, procedure time was 121 minutes. Pathology findings were high-grade dysplasia, HGD, 5%, or esophageal adenocarcinoma, EAC, T1a, 43%, or T1b, 52%. Among resections of HGD or T1a EAC lesions, 87% were both en-bloc and R0. The corresponding value for T1b EAC lesions was 49%. Among R1 resections, 10 of 34, 29%, showed residual cancer, all detected at first endoscopic follow-up. The remaining 24 patients, 71%, showed no residual neoplasia. 6 of these patients underwent surgery with no residual tumor. The remaining 18 underwent endoscopic follow-up during median 31 months with 1 local recurrence, annual recurrence rate 2%. Among R0 resections, annual local recurrence rate during median 27 months was 0.5%. Conclusion. In expert hands, ESD allows safe removal of bulky intraluminal neoplasia and submucosal cancer. ESD of the latter showed R1 resection margins in 50%, yet only 1/3 had persisting neoplasia at follow-up. To better stratify R1 patients with an indication for additional surgery, repeat endoscopy after healing of the ESD might be a helpful possible prognostic factor for residual cancer.